seen in association with end-stage liver disease, cirrhosis, and you can see that it's a serious diagnosis. You see that this is a chart of the percent survival patients following the first variceal hemorrhage, and so you see that 30% of patients died during the first episode. Okay. And after, 2 years, 24 months, less than 50% of patients are alive at 2 years. So some of that reflects the varices itself, and some of it reflects the prognosis associated with the underlying liver disease. Okay, let's talk about diseases of the stomach. We're on page 74 now. And again, as we go through these materials for GI, you should think about the review of systems that you ask the patients at the time of when you take an H&P. Think about all of the GI review of systems questions, and now you can start correlating those questions with, why am I asking those questions? And this will give you some insight into why you're asking those questions. Let's talk first about peptic ulcer disease. And peptic ulcer disease includes both gastric ulcer and duodenal ulcer. And as a prelude to their discussion of peptic ulcer disease, they talk about gastric acid secretion, and they talk about that in figure 4.2. And you can also refer to this slide, which goes into just a little bit more detail. But if you look at figure 4.2, what you'll see is that there are a number of substances that play a role in promoting acid production by the gastric parietal cell. So histamine has a role in the production of, has a stimulatory role in the production of gastric acid production. And that's why H2 blockers were, they still are, but there was a time when that was really the only pharmacological stuff that we had, except for antidepressants. Gastrin, the hormone gastrin, has a stimulatory role in producing parietal cell acid. And acetylcholine, which explains why in the old days the surgeons used to do vagotomies on patients that have peptic ulcer disease to interrupt this pathway right there. And then you see that there's a number of substances that have an inhibitory effect, if you will, on acid production, including prostaglandins. We're going to talk about that and the importance of that in a second. So what you see here is that all of these substances, all of these inputs, have either a stimulatory or inhibitory role in the production of parietal cell protons. But now we have these substances, proton pump inhibitors, which directly inhibit the business end of acid production. And so you can bypass all of these other inputs that we used to have to do, and we can go directly to the source of the acid. So that's why they're so powerful. Okay. In terms of the genesis of peptic ulcer disease, there are two ways, basically, that the patient can develop an ulcer. One is either because there's a defect in the ability of the mucosa to protect itself, or the other possibility is that you have a mucosa that is completely normal in terms of its ability to protect itself, but it's being overwhelmed by acid production. So those are the two mechanisms, and they're depicted in figure 4.3 on page 75. One is that you have hyperacidity. That's one mechanism. The other mechanism is decreased mucosal protection. And they list the different entities that are associated with ulcer production and the mechanism by which they do it. Okay. So let's talk first about decreased mucosal protection. And what you can see, if you look at figure 4.3, is that there are three, they list H. pylori, use of non-steroidal anti-inflammatory drugs, and stress as producing ulcers, peptic ulcers, by it having a deleterious effect on the ability of the mucosa to protect itself. It points out that the NSAIDs, they decrease mucus secretion. And it's that realization that gave rise to the development of the COX-2 inhibitors, which leave the mucosal protective enzymes in the bowel relatively untouched. Hypergastrinemia, as you see with patients that have gastrinomas, hypergastrinemia is associated with the development of ulcers because of hyperacidity, increased acid production. And they point out that if you have somebody that presents with multiple ulcers at multiple sites, you need to think about the possibility of Zollinger-Ellison syndrome or Wheaton syndrome, as it's otherwise referred to, which again is caused by a gastrinoma or gastrosecreting tumor. All right. The third possibility is that you have something that can affect both acid production and mucosal protection, and they give H. pylori as the paradigmatic example of that. So H. pylori is the one cause of ulcer formation that they're depicting here that causes ulcer by both mechanisms. Okay, as opposed to hypogastremia, which is just hyperacidity, and the NSAIDs and stress ulcers, which are just the result of problems with mucosal protection. Okay, so they're referencing here's the H. pylori infection, increased gastric release. As a result of that, that produces increased acid output. It's going to lead to ulceration. Let's see if they mention the ability of decreased mucosal defense. We have both of these mechanisms mentioned in the ulcerogenesis related to H. pylori. Okay, so that's both the ability of the mucosa to protect itself, and it also causes hyperacidity. Okay, in terms of the signs and symptoms of peptic ulcer disease, again, go back to the GI review systems. Nausea, vomiting, which could be of coffee grounds, it could be of bright red blood. They can present with melanoma. They can have we'll talk about the changes in appetite shortly. They can have pain associated with the septic ulcer disease. And then if the patient develops a complication of the septic ulcer disease, you have to be aware that they may present with a complication of the septic ulcer disease. So, for example, patients that have a severe ulcer can develop perforation into the peritoneum. They can develop signs of peritonitis, or they can develop penetration. They can also penetrate into the rectal peritoneum. They can develop with back pain. So all of these things are possible. Let's talk now about the effect on appetite. We're going to do that in the context of this book's discussion of figure 4.5 on page 76 and the timing of ulcer symptoms. So consider first a patient that has a duodenal ulcer. Actually, let's consider first the patient that has a duodenal ulcer. The patient that has a duodenal ulcer typically presents with symptoms, pain, 2 to 3 hours after a meal. That pain can be relieved by the ingestion of raw food or of antacids. And 2/3 of these patients describe pain that wakes them up. They describe hyperphagia, means eating more than usual. And you can see weight gain in such patients. And pain, pain makes the eating makes the pain better, hunger makes it worse, so they eat, they gain weight. Duodenal ulcer. The gastric ulcer, the symptoms typically occur sooner after meals than they do with duodenal. So if duodenal ulcer is 2 to 3 hours, this is going to be less than that. These ulcers are typically associated with anorexia and weight loss in up to half of patients. So now you should be aware that patients that have duodenal ulcers are almost always benign. They're almost uniformly benign. Gastric ulcers, that's the same statement cannot be made. The concern is that when a patient presents with a gastric ulcer, the question is it a benign gastric ulcer or is it the result of a gastric carcinoma, the malignant ulcer? And so if the patient complains of weight loss and anorexia, of course that's going to lead you, in most cases, to suspect malignancy. Anorexia and weight loss make us think of malignancy, or should make us think of malignancy. But you do need to keep in the back of your mind that sometimes just a benign gastric ulcer can also be associated with anorexia and weight loss. So basically, patients that have duodenal ulcers, usually those patients, they don't need to be subjected to any things to rule out malignancy. But patients that have a gastric ulcer, you do need to take some steps to make sure that they're dealing with malignancy. So oftentimes those patients have a biopsy to exclude the possibility of gastric cancer. Another approach would be to treat them for a benign lesion, but then to re-image them to make sure that there's complete healing, and re-scope them sometime later to make sure that the ulcer is healed. Okay, in terms of the treatment, obviously the treatment is going to depend at least in part on the cause of the ulcer. If you're dealing with an H. pylori ulcer, okay, sometimes the diagnosis can be made at the time of biopsy. If you're dealing with H. pylori ulcer, those people are going to be treated with a regimen that's designed to eradicate the H. pylori. Did you study the pharmacology of the eye system there? Did you study H. pylori and pharmacology? Yeah, there's different regimens that you can use to wipe out the H. pylori. So it's usually multiple drugs. So that would be the first step to dealing with somebody that has H. pylori ulcer. If the cause of the ulcer was something else, then the treatment is going to be tailored in that regard. So, for example, if somebody has a gastrinoma, if that's something that needs to be addressed surgically, then it will be addressed surgically. If you want to shut off the hyperacidity in the meantime, again, you can use multiple agents, but the ones that are most commonly used nowadays is most potent proton pump inhibitors. They reference the role of H2 blockers and vagotomy. Vagotomy more of historical interest. The H2 blockers it used to be all that we had pharmacologically. Now they are still useful. They're available over the counter, and they work pretty fast. The onset of action is faster than the proton pump inhibitors, so that's something that weighs in the favor of their use. So this is some of the surgical procedures that have been done for peptic ulcer disease. The selective vagotomy was when they were interrupting the connection between the vagus nerve and that portion of the stomach that has parietal cells. Okay, and then that's what I wanted to show you. Other things that can be done include interventions to increase the mucosa's ability to defend itself. So they reference sucralfate, which is basically a substance that sort of forms a slurry. The person drinks it down, and it sort of forms a barrier that protects the gastric mucosa against acid. The proprietary name is Parafate. Sucralfate is Parafate, Parafate. And so, for example, if you look at the figure 4.3, if you have somebody that has stress-induced ulcer, stress is playing a role in the genesis of the ulcer, Parafate would be a good thing to use. We also, on one point, had a patient who had a so he had a connection between the stomach and the abdominal wall. And outside the here's the stomach. And here's the abdominal wall. There's a stoma. There's the stomach, here's the abdominal wall. And outside, if we're looking at it from the outside, there's a little stoma with the opening going into the stomach. Okay? And then you have like mucosa around it. Okay? And of course, you put a dressing over this to keep it from leaking. Anyway, he developed an ulcer or a wound on the stoma, and so he had seen a number of people trying to get it to heal. It wasn't healing, and So what we did is we put them on carotene, on this, and it healed like a week or so. So I hadn't used carotene for a long time. Worked that fine. Good. Okay, so that's sucralfate, and then the other thing that the book talks about is bisoprostol, or the trade name is Cytotec, Cytotec. He points out that it is a prostaglandin, and again, look at figure 4.2 on page 74. You see that has an inhibitory effect on the parietal cell, so it increases mucosal secretion, prevents against ulcer formation, and it is used in the Cytotec is used in the prevention and treatment of septic ulcer disease in people who need to continue taking nonsteroidals. So if you have somebody that you can't take them off the nonsteroidal, they need to be on nonsteroidal, but they have they're at risk of the development of an ulcer, you can use Cytotec, or you can just put them on max doses of an H2 prototypic inhibitor. Okay, and then what this slide is meant to depict is when a patient presents with septic ulcer disease, oftentimes they present with an upper GI bleed. Okay, so they'll present with melanoma, or they'll present with hematemesis, something like that, multi-ground emesis, what have you. And so what happens is that the gastroenterologist takes them to the endoscopy suite and they endoscope them. They look to see where the bleeding is coming. And what this slide shows you is if you take all comers, people who have septic ulcer disease associated with a bleeding presentation, what are you likely to find when you look in their stuff? So this shows you the prevalence, what you're likely to find. So this is 42% of the time you're going to find that. Okay, and 20% of the time you're going to find that. But what's most important about this is that you can also predict the incidence of rebleeding. And that's, of course, it's important to know. The critical question is it okay to send the patient home? The patient just vomited blood, or had a GI bleed, is it okay for me to send them home? When is it okay for me to send them home? And what this says is that depending on what you see, you can predict what the incidence of rebleeding. So obviously, if somebody's actively bleeding, that's associated with the highest likelihood of bleeding. You wouldn't send that person home, right? But you see, if they have a non-bleeding visible vessel in the base of the wound, that's also associated with a very high risk of rebleeding. And as you move from left to right, or right to left, the incidence of rebleeding goes down. So with a clean base, the risk of rebleeding is only 5%. All right? So that's one of the reasons that they get endoscoped. Sometimes they need to do an intervention at endoscopy, but sometimes it's just to see what the risk is, what the prognosis is in terms of rebleeding. All right. Any questions about septic ulcer disease, gastritis? Okay. The other thing that when we talk about the esophagus, we say the esophagus is basically just a conduit from the mouth to the stomach. So the things that go wrong have to do with like motility disorders, overactive muscles, underactive muscles, obstruction, reflux. The stomach is more active than the esophagus. It is more physiologically active. And so the things that can go wrong are increased. Remember we said that it has a third muscle layer that the rest of the bowel doesn't have, like diagonal fibers that are responsible churning and the breaking up mechanical processing of the food that enters it. But the stomach is also important, for lack of a better term, endocrinologically or immunologically. It's responsible for the production of intrinsic fat. The parietal cells, besides producing acid, produce intrinsic fat. Intrinsic fat is needed in order for the body to absorb dietary B12. And we've alluded to the disease that's associated with B12 in neurology. We talked about pernicious anemia, and we talked about how it's associated with neurological problems, including some acute combined degeneration, and we said that it's associated with disease of the posterior column. Notice that they have problems with the difficult vibration sense and unconscious proprioception, discriminatory touch, all that stuff. So besides, so they can get subacute combined degeneration. They can develop patients with B12 deficiency can develop something called megaloblastic madness. Remember that it is on the differential diagnosis for the patients that present with dementia. They said that you have to exclude the reversible causes of change in mental status before you say, all right, the person has dementia. One of the things that you have to exclude, we talked about thyroid disease, we talked about syphilis. One of the things we talked about, remember, was B12 deficiency. So you always check the B12 levels to present that way. Diseases of the posterior columns. They can also develop a peripheral neuropathy. B12 deficiency is also associated with peripheral neuropathy. So they can prevent weakness. Patients that have pernicious anemia, patients that have B12 deficiency as a result of pernicious anemia, have a disease, as the book makes clear, in which antibodies are formed against the parietal cells, which leads to the loss of intrinsic factor. So the parietal cells are responsible for the production of intrinsic factor. Patients that have pernicious anemia develop antibodies, oral antibodies, to their own parietal cells. So the parietal cells are going to be attacked. They're not making intrinsic factor. Of course, they don't make an acid either, right? I think and basically what they say is that we'll talk more about that in chapter 6 when we talk about the importance of B12 in the production of the red cells. But for now, just try and tie this stuff in with what we learned about B12 deficiency when we talked about neurology. Okay, obstruction. So now what we're talking about is gastric outlet obstruction. Gastric outlet obstruction. And they give you a couple of different things that can cause gastric outlet obstruction. Here's the pylorus. Okay. The food has to pass through the pylorus channel to get into the duodenum. So we're talking about obstruction at this level. Prevent the food from going to the gastric outlet into the duodenum. And they give you a number of entities that can cause that. They say obstruction can happen as a result of the ingestion of a foreign body. It can happen from a gastric polyp or a gastric tumor, gastric cancer. It can happen from scarring. So let's say you develop acid ulcer in the pyloric channel, and you get chronic scarring related to the hyperacidity. So if you get scarring, you can imagine that would produce obstruction, just like we saw scarring produce obstruction in the esophagus. They talk about pediatric disease, congenital pylorostenosis, which needs to be considered in the newborn and the neonate. And then you can get extrinsic compression of the failure from the tumor outside of the stomach or the duodenum. And they talk about the possibility of pancreatic, and the pancreas is going to sit right here, it's going to be nothing right here. So pancreatic tumor might theoretically cause compression and obstruction at that point. Patients that have obstruction of the pylorus are going to complain of early satiety, nausea, vomiting, abdominal distension, and this is a patient that has gastric outlet obstruction with gastric outlet obstruction due to hepatitis disease or a distended and filled stomach. Okay, so obviously this person was imaged, I guess, in order to exclude the possibility of a tumor that might be causing this. Okay, and apparently they did not find the tumor; they just attributed it to hepatitis disease. The other thing that you see is that how large the stomach is, how usually distended it is. Okay, and you see that this person has lots of fluid in it and also lots of air. Okay, and these people, you can appreciate something called a percussion splash on physical affairs. That go like percussion splash. Okay, so make sure you read about percussion splash. Okay, but you can actually hear the splashing of the contents if you move them around and you listen with your stethoscope. You can hear the so-called percussion splash, which is going to be suggestive of a situation like this, where you have extended stomach, lots of gastric contents for there. If you had a patient like this, forget about the CAT scan. Let's say you had a patient like this and you didn't have a CAT scan. Okay? You had a patient that had signs and symptoms of gastric outlet obstruction and had a percussion splash on physical diagnosis. Okay? And when you're examining them, you notice that they have a supraclavicular lymph node. Supraclavicular lymph node. What did you conclude? Does anybody know, by the way, what that node is called? It has a name under these circumstances. Okay, it's called a Virchow node, V-I-R-C-H-O-W, Virchow node. And it's suggestive of metastatic gastric CX. Okay. What happens if same patient, but they don't have a supraclavicular lymph node, they have a periumbilical nodule. Periumbilical nodule. That's called a Sister-Mary-Joseph nodule. See the nodule right there? And this was named after, this is images in clinical medicine, in the New England Journal of Medicine. This was named after a nun who used to work, I guess, at a Catholic hospital, and she would assist the surgeons. I guess it must have been a cancer ward or something like that, or GI ward or something. She would assist the surgeons in terms of prepping the patients for the surgery. And after they had a number of cases of patients that had gastric cancer and had this unusual finding, and they recognized that there was a link between this finding and the gastric cancer. Okay? So it's taken her name, it's a Mary Joseph nodule. Let's see, it says it here, surgical assistant for Dr. William Mayo, who noted the association between paraumbilical nodules observed during skin preparation for surgery of metastatic intra-abdominal cancer confirmed that surgery. By the way, there was a book. Yeah, go ahead. Virchow is a supraclavicular lymph node. What? It means that it's a finding in patients that have metastatic gastric cancer. Virchow is the pathologist. It's probably it's named after the pathologist. Is that the question? Is it always the left one? I don't know if it's always the left. I don't know. So in my notes it says left. In my notes it says left. So there was a book that came out. What's the best? 25 years ago, something like that. It was called something about Dracula. I can't remember the title. Anyway, it was Dracula, but Dracula in the story was a doctor in training in a hospital in Germany. Anyway, something about Dracula, and there's a scene in the book where he's there it's a great scene. He's there at the bedside with his attending physician, okay, and so the attending physician does examination, and then he starts looking at the patient. He says, no, man, put your hands on the patient. So he goes to feel, he's feeling the patient, and it's a woman, and he gets to the supraclavicular, and he realizes that she has a supraclavicular lymph node. And so and he already knew the history. I can't remember the history, but it had something to do with the GI tract. So the attending asks him, well, and he goes, do you know what she has? And he goes, yeah. And he goes, well, tell me. He goes, I hesitate to say. He doesn't want to say in front of the patient. And he goes, well, tell me the answer or somebody else gets the credit. He starts turning to the medical student. So he says, that is gastric cancer. The woman becomes hysterical. He breaks down. And the attending is like, very good, very good. And the woman is hysterical, and he goes, okay, well, we'll meet for the nurses, and they walk away. And it's just a great scene. I mean, it wasn't high literature, this book. I got to figure it out. Anyway, it wasn't a great, but the scene was really well done. And it's a great thing to use to illustrate like how not to teach at the bedside. Yeah.
Different signs indicate like metastasis are not going up towards the lungs and brain, or taking areas that we want to go into the liver.
Well, this is local spread in intra-abdominal carcinosis. So I don't know. I don't know how those two things relate to each other. If one is more, this is again local spread, local metastasis. So I don't know if those two courses are completely different or if there's some overlap. Okay. All right. So okay. So that's it for obstruction. Okay. Count Laszlo something. Count Laszlo. Laszlo. Hold on a second. I can't think of anything else now. What is it? What? Yes, that's it. Laszlo Count Dracula. That was it. Yeah, so he's a doctor in the book. So, and I don't remember anything else in that book except that scene. That one scene. It's the only thing I remember. I don't even remember how it ends. I don't remember he bites anybody. So, all right. All right, we'll do gastroparesis and gastric cancer, and then we'll stop at the diseases of the small intestine. Okay, so the gastroparesis refers to basically a motility disorder of the stomach. Okay, the stomach basically is not peristalsing and contracting as it should in order to propel food forward along the GI tract, and so it's not propelling food this way, and it's not doing its job in terms of helping to digest the food. And this is most commonly seen. You can see it in a number of conditions, but it is classically seen in patients that have diabetes mellitus and diabetic neuropathy. But as you might imagine, if you interrupt the vagus, right, if you do a vagotomy, you can imagine that that's also going to interfere with motility, because that neural input is important in terms of motility. So if there's a vagal injury, that can cause problems with diabetic gastroparesis. When we put people to sleep with anesthesia, of course that puts the bowels to sleep, including the stomach, and so they can develop a transient, obviously, it's a transient diabetic gastroparesis. Narcotics can do it. Parkinson's disease can be associated with gastroparesis. Multiple sclerosis can be associated with gastroparesis. Amyloidosis. What else would we say amyloidosis is associated with? We talked about it. Say it.
Restrictive lung disease?
Sorry? Restrictive cardiomyopathy. And scleroderma can also be associated with with gastroparesis. It affects the entire bowel. We talked about its role in esophageal dysmotility. Now, in terms of the last thing we're going to talk about is gastric cancer, which is treated at the top of page 78. They point out that in their discussion, they point out that many of the agents that can be associated with gastritis can also be associated with the development of gastric cancer, and they reference specifically H. pylori is a risk factor for the development of gastric cancer. They point out that most of the time, gastric cancer is adenocarcinoma of the stomach. That's more than 90%, by the way. More than 90% of the time, it's adenocarcinoma of the stomach. Other things that can occur in the stomach include the MALT tumors or the maltomas, mucosa-associated lymphoid tissue, and leiomyosarcomas, smooth muscle tumors. Interestingly, if the person has one of those mucosa-associated lymphoid tumors, if it's H. pylori associated, and apparently about 90% of them are, you can see either partial or complete regression of the tumor with treatment of the H. pylori. So that's kind of interesting. All right, so That's where we're gonna stop. Any questions about anything that we talked about so far today?